4, 3. Good morning here in Miami and good evening in Mumbai, India. This is Dr. John Bennett of Larkin Hospital TV, innovative way for medical education. Today we have the pleasure of having Dr. Neha Abichandani, whose husband also gives hangouts. And today Neha is going to talk about cricothrotomy and tracheostomy, a subject near and dear to many physicians. Good morning, Neha.
Hello, John.
Can you tell us a little bit about yourself first, please, before you start your slide presentation?
Yes, John, I have completed my master's in oral and maxillofacial surgery from India, and it's been 1.5 years since I've completed it. We have our own private setup. I have my own dental clinic in Mumbai, which I participate with my husband, Dr. Sagar Abichandani. So we handle our clinic. We have 5 specialist doctors with us, an entire team also which runs the clinic. So we've been doing great. Everything is going smooth, God's grace. And it'll be a pleasure to perform these lectures with you.
Very good, Neha. Okay, you're ready to roll with
Yes.
your slide presentation. This is Neha's first hangout, so.
Yes, John.
Okay. There you go. Perfect.
Hello, everyone. Today we'll be talking about 2 very important life-saving procedures, cricothyrotomy or cricothyroidotomy and tracheostomy, which are frequently used in an emergency setting for airway management. Securing and monitoring the airway are among the most important key requirements of appropriate therapy in an emergency patient. Failure to secure airways can drastically increase morbidity and mortality of patients in a very short time. Endotracheal intubation, as we all know, is often called the golden standard for airway management in an emergency. But multiple failed intubation attempts or contraindication to intubation will endanger the patient by prolonging hypoxia and causing additional trauma to the upper airways. This knowledge of alternative procedures is very essential and imperative in every emergency setting. 2 such procedures are cricothyrotomy and tracheostomy. Today, we'll be talking more on cricothyroidotomy in detail, and tracheostomy will be dealt in the part 2 of this lecture. Before we go into the details of it, just briefly briefing you on the respiratory system. The respiratory system basically consists of the upper respiratory tract and the lower respiratory tract. The upper respiratory tract involves the nasal cavity, the nasal passages, the pharynx, up to the vocal cords. Anything above the vocal cords or the voice box is a part of the upper respiratory tract, whereas anything below the vocal folds comes in the lower respiratory tract. The lower respiratory tract hence involves the trachea, the bronchi, the bronchioles, alveoli, and the lungs in particular. Now, most important structures which we need to know when we go into these procedures are as follows. Firstly, you'll have the thyroid cartilage. Now, the thyroid cartilage has something known as a superior thyroid notch and the inferior thyroid notch. The prominences on both the sides of the thyroid cartilage comes into the center to form a structure known as the thyroid prominence or the Adam's apple, known in layman terms. Now, this Adam's apple is a very important structure when you're performing any of these emergency procedures. Below your thyroid cartilage comes the cricoid cartilage. The cricoid cartilage is the second prominence which will be seen in your neck just below your thyroid cartilage. The structure, a fibroelastic structure in between the thyroid cartilage and the cricoid cartilage is known as a thyrocricoid membrane, a very important structure when you're performing cricothyroidotomy. Anything which comes below that are your tracheal rings. The tracheal rings, as we know, are said to be incomplete rings as compared to the cricoid ring. The cricoid ring is a complete elastic membranous ring which is present as compared to the tracheal rings. The tracheal rings are incomplete because posterior to the tracheal rings we have the esophagus. The rings are incomplete so that the trachea can collapse itself whenever food is passing down the esophagus. Now, the procedures which are performed today, which are cricothyroidotomy. Now, the cricothyroidotomy, as I said, is performed in this minute area. It is in between the thyroid cartilage and the cricoid cartilage in an area known as the cricothyroid membrane. Whereas another procedure, the tracheostomy, is performed on the second, third, and fourth tracheal rings. Now, as we compare these two structures, you can see the area where we perform cricothyroidotomy hardly has any important anatomical structures. So this procedure can be performed very easily even by a non-surgeon, whereas a tracheostomy happens to be a more difficult and a more risky procedure, because you can see the very vascular thyroid gland happens to be the area of tracheostomy. There are more important arteries which are seen traversing the area as well. So bleeding can be a very important thing which you'll have to manage in performing a tracheostomy. Now, going into this procedure in detail, cricothyroidotomy, tracheotomy, laryngotomy, high tracheostomy, low laryngotomy, and coniotomy are some of the anonyms which can be used for this procedure. It basically refers to the creation of communication between the airway and the skin via the cricothyroid membrane. There are actually three procedures which come under this. You can either perform it using a needle, you can perform it percutaneously, or an open cricothyroidotomy, which is a surgical cricothyroidotomy. Now, indications for surgical cricothyroidotomy or any form of cricothyroidotomy is basically when you cannot perform an endotracheal intubation, when there is any kind of contraindication for performing intubation through the oral cavity or nasal cavity. Basically, what happens is if you have performed many attempts in performing an intubation, like if there is kind of a hemorrhage, or if there is emesis, mesetaspasm, clenched teeth, any kind of a laryngospasm which prevents you from performing an intubation, then the most important airway which can be secured is by using a cricothyroidotomy. Now, you can also perform it if there is massive injuries to the face, like in this case, when there's traumatic injuries of the oral or nasal areas, maxillofacial injuries, or if the spine, cervical spine is highly unstable, because when you're performing an intubation, you'll be hyperextending the neck. It is contraindicated in a patient who has got a cervical spine injury. When you're performing a cricothyroidotomy, you don't need to hyperextend the neck, because you only need to see the anatomical structures in the neck. Extension of the neck is sufficient. You do not need to hyperextend it. So cricothyroidotomy is actually a procedure which can be performed in patients who have got a cervical spine injury, where you do not want to increase the damage in such situations. It can also be performed in some laryngeal surgeries, laser surgeries, bronchoscopies, etc. Now, talking a little bit on the anatomy of the structure. Now, this membrane which you're going to incise into is the dense fibroelastic membrane, which is seen, as I said already, between the thyroid cartilage and the cricoid cartilage. It's around 30 mm in width, but the entire width is 30 mm. There are two dense muscular structures which are seen, which actually hinders us in performing this procedure. So the area which you can perform the procedure is actually very limited. And how do we get into this membrane? Firstly, as I told you, you have to feel the Adam's apple in the neck, which is also known as the laryngeal prominence. This is the area which you'll be feeling for the laryngeal prominence. Dip down into that area and you'll enter into the cricothyroid membrane. The cricothyroid membrane is basically present between the thyroid cartilage and the cricoid cartilage. So the indentation or the notch, the dip which you get into once we come down the Adam's apple, is the area where you have to incise. Now, there are some contraindications when you go into cricothyroidotomy. The first absolute contraindication is if you can perform an intubation in a patient, never perform cricothyroidotomy or tracheostomy. Always, first, the easiest step has to be performed. If you cannot go ahead with your intubation, then only you go into the second stage. And secondly, if there is any transection or your trachea is damaged and the trachea has entered into the distal end of your mediastinum, when you feel that if you perform your cricothyroidotomy, there can be any more damage to the mediastinum, or there can be hemorrhage into your mediastinum, never enter into doing such a procedure. Or if you have fractured larynx, you know that there's a damage to the upper upper airways, never go on to perform a cricothyroidotomy. These are your absolute contraindications, whereas relative contraindication is do not perform these procedures in young children or infants because your structures are not very well developed. For example, they do not have the Adam's apple, their laryngeal prominence is hardly developed, and the membrane where we have to perform this procedure itself is very tiny, so you'll be creating more damage than actually without doing this procedure. And if there is any kind of bleeding in that area also, it can be a relative contraindication. And if there is massive neck edema because of which the structures cannot be clearly seen, then also do not go ahead with this procedure. Now, as I already said, why is it contraindicated in children is, first of all, surgeons preferably tell that till 12 years of age, as far as possible, do not perform such procedures on children. Because as I already said, the Adam's apple or the laryngeal prominence is not well developed in them, and the larynx is said to be more funnel shaped, and compared to adults, it is at a much higher level. So you might miss the anatomical landmarks when you're actually performing these procedures. The cricothyroid membrane itself is very small. The cricoid cartilage is said to be the narrowest part in the child's neck. And secondly, in these children, because of the tiny structures, even if a tiny incision in this area in future will lead to subglottic stenosis. Now, when you go into procedures, as I've already said you, there are three structures which you have to keep in mind: the thyroid cartilage, the cricoid cartilage, and the space in between where we are going to produce the procedure, the cricothyroid space. The first is when you're doing it in an emergency, extreme emergency, you do not have any emergency instruments. The only two things which you require is a very sharp knife or a very sharp blade and a hollow tube. But if you're performing it in an ICU or an emergency setting, you basically require a scalpel with number 15 blade, a tracheal or a tracheodilator, two hemostats, the curved Mayo hemostats, curved Mayo scissors, the tracheal hook, needle holder, tracheostomy tube. It's very important in these situations that you take the exact number of tracheostomy tube, because if you're taking a smaller number tracheostomy tube, then the secretions which are produced is going to clog the tube. Whereas if you're taking a larger size, then you will be causing damage to the larynx as well as laryngeal fractures. So in these situations, as I've already told, the exact measurement of the membrane is around 30 mm. So ideally, you will have to fit in a tube which has an internal diameter of around 9 to 10. So that will come into a tracheostomy tube of around 5 or 6 numbers. So based on the females, you might fit into a tracheostomy tube of number 5. For adults, you might require something around 5 to 6. For sterilization, you will be requiring your gauze pads and everything which is required to sterilize an area before you go into the procedure, and sutures or anything like a circumferential tie to secure the airway. Now, as I've already told about the tube, it's very important that you take up the exact number of tube when you're when you're actually going to secure the airway in these emergency situations. Now, how do we go about this procedure? First of all, if it's an emergency setup, first negate whether you want to give a local anesthesia or not, because what happens is it's an emergency situation. The person is not going to worry about a little bit of pain which a cricothyrotomy is going to produce, as compared to wasting the time when you have to give a local anesthesia. And in these patients, there's respiratory depression in such patients. So if you're going to give them general anesthesia or kind of sedation, then it will worsen your respiratory depression, leading on to buildup of carbon dioxide, which can further worsen the situation in these mentally unstable patients. So instead of that, directly, if you feel that there is a kind of hindrance for time, then directly go into the procedure. And hyperextension of the neck is required, not as much as your intubation. Just extend the neck so that you can see all the landmarks in this area. So first of all, what you'll be doing is feeling the Adam's apple. Once you feel the Adam's apple, slowly move down your index finger. You'll feel a depression between the Adam's apple and the second bony prominence, that is the cricoid cartilage. Once you have felt it, you will be taking your thumb and holding it onto your Adam's apple. The second structure is the cricoid cartilage. Your middle finger will be holding onto your cricoid cartilage. Your index finger will be free to move in between the cricothyroid membrane. Now there are two kinds of incisions which can be used. If it's an absolute emergency where you do not have time to think about the incision, just give a vertical incision which is around 3 to 4 centimeter long in between the two cartilages. Now, basically, why do you use a vertical incision and not a transverse or a horizontal incision is, if you feel that you have gone too much lower down, and if you give a transverse incision, like for example, you've given a transverse incision which is way below and you've encountered the thyroid gland, there's extreme bleeding, you need to go more superior. That time you'll have to give a second incision if you're given a horizontal incision. But if you're given a vertical incision, if you have to go superiorly, you just have to extend the incision. But that is not possible if you have a transverse incision. So always, if it's an absolute emergency, just give a vertical incision. If you feel it's an elective procedure, then give a transverse incision which is around 2 centimeter in width, which is more cosmetically improving. Then once you've given the incision, you slowly reflect the tissues, and once you've given the incision and you go deeper, you will be getting the membrane known as the cricothyroid membrane. You see the membrane. Now it's very important that you take a tracheal hook and engage it into your thyroid cartilage so that the visibility becomes more, and you should make sure that the tracheal hook is in place so that the larynx doesn't collapse down posteriorly, because if the larynx collapses down posteriorly, it becomes very difficult for you to visualize, and you might be placing the tracheostomy tube into your mediastinum, or it may rupture your esophagus as well. So a very important thing you have to do once you have reflected is hold on to the tracheal hook onto the thyroid cartilage. Next, once you're given the incision, you will be giving a 1 centimeter stab horizontal incision into your membrane. So you give a 1 centimeter stab incision, and it's very important that you give it in caudal fashion. That is, your scalpel should be coming in caudal fashion so that you do not injure the vocal cords, which is because any kind of vocal cord injury is going to impair his speech. So once you've given a 1 centimeter stab incision, once the scalpel enters the tip of the scalpel, it's very important that only the tip of the scalpel enters into it so that there's no damage to the structure posteriorly. So once the tip of the scalpel enters into the larynx, you get a popping sound. That is the indication that you have entered the larynx. And it's very important when you're giving the incision, you give it more towards the cricoid cartilage. You give it very inferior in the membrane. Do not give it superior, because you have the cricothyroid artery, which is seen actually transversely in the lower part of the thyroid cartilage. So always give the incision towards your cricoid cartilage and not towards your thyroid cartilage. Once the 1 centimeter stabbing incision is given, stabilize the entire thyroid cartilage by your larynx holding the finger. Take up a curved manual scissors and expand the incision, which you give it very slowly. Once you've expanded the incision, you feel your tracheostomy tube can enter into the incision. Take up your tracheostomy tube, enter into the two beaks of your manual scissors, enter your tracheostomy tube into it, and secure it in place. So once you have secured the tracheostomy tube space, check for the saturation, for the airway movements, lung movements, check for chest expansions, check for any kinds of things which actually hinders in respiration. Make sure that everything is in place. Then you can secure the tracheostomy tube into your using your sutures or even elastic band, which is seen in this case. After this in place, should you go ahead and secure the intervention? So the precautions which have to be taken in the surgical procedure is, first of all, avoid too laterally, because if you go too laterally, you'll be encountering all the major blood vessels. Bleeding can become a very major hindrance in such procedures. And finally, you shouldn't go too caudally as well, because you'll be encountering the highly vascular thyroid gland, and any bleeding which produces from the thyroid gland can be very difficult to manage. So always your area of work should be in between the cricoid cartilage and the thyroid. Never go too intricate. And the stabbing incision, as I always told you, should be near the cricoid cartilage and thyroid cartilage, because the cricothyroid artery is traversing close to the thyroid cartilage. And we are supposed to avoid any cartilages, and when you're entering, always enter 90-degree posteriorly, or you should enter the scalpel in a caudal fashion so that there is no damage to your vocal. Avoid any blind stabs. Always keep in mind the anatomical landmarks when they're going into those procedures. And always the scalpel, which is when it is entering into the larynx, should be only the tip of the scalpel, because if you enter the entire via scalpel blade, you'll be encountering the esophagus in no time, and any esophageal rupture can be a double emergency. And always place a correct tooth size so that you do not fracture the ladder. Complications which are seen after surgical cricothyroidotomy immediately. Actually, the complications compared to tracheostomy are very minimal, but few complications can be encountered if the procedure is not performed correctly. Most importantly, is it can be controlled as well. Bleeding, incorrect tube placement, unsuccessful tube placement when you place it into the intestine, you place it into the esophagus, prolonged procedure time. You should keep in mind that cricothyrotomy, if performed correctly, should be complete within 3 minutes. Anything more than 3 minutes, either you are actually anything more than 3 minutes is you are in an incorrect frame, and it has to be corrected before you actually proceed with the procedure. Subcutaneous emphysema because of air passages, obstruction because of any kind of mucus plug. Infrequently, you can also come across esophageal perforations if they're going back too posteriorly, mediastinal perforations, vocal cord injury if you have taken a scalpel too superiorly, laryngeal fractures if the size of the tube is incorrect, aspiration. Most common complications you must remember, which can happen after 1 2 months of time, is if there's any voice changes. That is, you have damaged the vocal cord, so there could be dysphonia, infections which can take place if you have not maintained sterilization, late bleeding, persistent stoma in the site of incision, and sometimes most frequent things which we see is your glottic or subglottic stenosis, transesophageal fistulas, tracheomalacia, etc. The second thing which is easily performed in this situation is a needle cricothyroidotomy. In needle cricothyroidotomy, the only important instrument which you require is a 12 or a 14 gauge needle. Now, this process you must keep in mind is an inguinal motion. The needle cricothyroidotomy provides only a little bit of oxygen which can maintain the airway for maximum 45 minutes. After 45 minutes, you should think about either intubation, cricothyroidotomy through a surgical procedure, or a tracheostomy, because after 45 minutes the hypoxia will start setting in because of reduced oxygen, carbon dioxide will start building up, and a person can end up in another emergency because of this increased carbon dioxide level. So always needle cricothyroidotomy has to be performed in an extreme emergency situation, but make sure you go on to the second step within the 45 minutes, secure the airway. Now, needle cricothyroidotomy requires only a needle with a bent so that it enters into the trachea easily. Same landmarks have to be kept in mind: the Adam's apple and the cricoid cartilage, and you enter into the cricoid cartilage with a syringe which is filled with saline. So once you enter into the cricothyroid membrane, once you enter with negative pressure, you have to take in negative pressure, enter into the membrane, you will get air bubbles once you get into your larynx. Once you get air bubbles, it confirms the placement of the needle. Slowly remove the syringe out of it and place an endotracheal tube into the syringe, and you can give the oxygen either through an ambu-bag, or you can directly attach it to the emergency setup. Now, what is usually seen in emergency setup for airway management is you can give intermittent high pressure jet ventilation. The high pressure jet ventilation in between makes sure that the oxygen levels are stabilized, and you can actually increase the time of the setup to at least 45 minutes to 1 hour by making sure you give high pressure oxygen intermittently. Instead of giving controlled oxygen throughout the procedure using an ambu bag, you can give every 5 minutes, you can give in high pressure jet ventilation so that the oxygen levels are maintained better. Once you have performed this procedure, there are a few complications which are seen in this procedure as well, which are pneumothorax. Because you're pumping in oxygen through a jet ventilator, there could be damage to the airways which are seen. Because of this, the person may end up with pneumothorax, emphysema, bleeding, esophageal rupture if you have punctured through the esophagus, and long-term complications in this case are subglottic stenosis, vocal cord injury, remain the same as compared to a surgical procedure. Now, there is a third procedure which can be performed by using a percutaneous technique, which is also called the Seldinger's technique or the Seldinger's technique, which basically includes a syringe needle. Along with it, you have a dilator which is attached to your tracheostomy tube. How do you perform this procedure? In this procedure, unlike the needle cricothyrotomy, you give a stab incision around 1 centimeter in the region of the cricothyroid membrane. Once you give the stab incision, same needle has to be put into with saline, and once you enter into the larynx with negative pressure, you will get air bubbles. Once you confirm the air bubble with the filling is in your larynx, you will be passing through the needle guide wire. So remove the syringe, pass a guide wire through the needle, and confirm the guide wire in the larynx. Once the guide wire is in larynx, slowly remove out the needle. Once the needle is removed through the guide wire, you will be passing the tracheostomy tube and dilator. Confirm the placement, confirm the oxygen level, confirm that the movements of the chest are normal, remove the guide wire and dilator carefully, and the tracheostomy tube is in place. Tracheostomy tube is then secured using your sutures or your elastic band. So this is your percutaneous technique. I will make an incision and then passing the needle and then the dilator as well as the guide wire to confirm the placement of the tracheostomy tube. The complications remain the same in this procedure as well. Early, because you given incision, there might be bleeding. Sometimes the guide wire, because it's very sharp, can penetrate paratracheally. It can go to the mediastinum. It can cause damage to other structures that you have to be very careful of. Esophageal ruptures can occur because esophagus is present just posteriorly. Pneumothorax, surgical emphysema. There are a few late complications in this step as well, like subglottic stenosis. There, if you're damaged, the root cause, as usual, you have dystonia, persistent stoma, transesophageal ruptures, etc. And now, there are a few advantages of surgical cricothyroidotomy over tracheostomy, which you must remember when you're performing it. Tracheostomy is a golden standard when you're performing a very emergency procedure. But why do you indicate cricothyroidotomy? Firstly, it's very subcutaneous structure. The cricothyroid membrane doesn't require any kind of deep dissection. Just you have to pass through a subcutaneous tissue and then you end up in a cricothyroid membrane. There is absence of emergency and very critical structures in this area. There is no gland, there are no important blood vessels, there are no important nerves which you have to encounter when you're doing the procedure. They're easily seen landmarks like your adducts and your record cartilage are all easily seen, and compared to your tracheostomy side, the cricothyroidotomy side is away from the mediastinum, so all the important structures that are coming in your mediastinum are far off. The advantages comparatively are it's easier, it's faster, it is safer, it doesn't require an operating room because I've already told you just a scalpel and or hollow tube, which is what you require for cricothyroidotomy. You do not require to hyperextend the neck, so you can do it in a person who has cervical spine injury. It has a better cosmetic appearance of the scar. There are decreased late complications as compared to tracheostomy, and the decreased incidence of early complications like pneumothorax, pneumomediastinitis, mediastinal perforations, etc. And most importantly, it can be done by non-surgeons as well in a setting which doesn't require an ICU and it requires minimum number of instruments. Now, the part 2 of my lecture will be the tracheostomy, which is a very important medical procedure which has to be done in an emergency setup. It is a more complex procedure. It has more number of risks that are taken into, but it can be dealt properly if anatomical landmarks are kept in mind and you stick adhere to the protocols which have been put forward by surgeons over the period of time. Thanking you, everyone, and have a good day.
Thank you very much, Dr. Neha Abhi Chandani from Mumbai, India. You can get off the screen? You can get off the screen share now, Neha. And could I ask you a few questions, please? I'm going to make a few comments, okay, and questions. Is that okay?
Yes, John.
Yes. You know, I speaking as an ex-ER doc, I can say that this is one of the most pressure-packed situations in the emergency room.
Yes.
A difficult airway, as you know, it is very, very intense situation, and it really helps to know it well, to know, you know, the step, just like you outlined very clearly, the steps you need to do and the anatomy you need to know, and that will aid you in being better at it if you really knew the procedure well before you touched the patient.
Exactly.
Now, in your experience, do you find that when someone makes the longitudinal incision, is it too high or too low?
Yes, John.
I know it's not easy to get it the first time, but generally, do you find that people make it too high or too low?
No, the thing is, John, if you give a transverse incision which is too low, what happens is an emergency situation. If you have encountered the thyroid gland, it has started bleeding, then you
Right.
have to repeat the incision. It becomes very difficult. You're performing a second incision in the case of an emergency. Instead, if it's an absolute emergency, if you perform just a longitudinal incision, feel your Adam's apple, feel your cricoid cartilage, just give a longitudinal incision in between them. And if you feel you've gone too much inferiorly, you just have to extend the incision superiorly. You do not have to give a second incision. So you're saving a lot of time. So I feel in absolute emergency where cosmetics is not a concern, always give a longitudinal incision.
Now, you're being an oral surgeon, you must be very comfortable with the anatomy, correct?
Yes, yes, John.
Yeah, you spent a lot of time in that area, right?
Yes, John.
Oh, that's good. Well, have you been called to the ER to do this on an emergency basis?
We have always assisted our senior surgeons, John. And personally, we always had a senior surgeon standing behind us when you're doing this procedure.
Okay.
Here, actually, I've not had a hands-on once I've come to Mumbai. I've done my graduation from Karnataka, that is another state compared to Maharashtra. So there we have not performed it without a senior surgeon's assistance. Here, as of now, I'm not associated with any hospital, but if I do in an emergency setup, I'm always comfortable doing the procedure.
Yeah, that's good. You have to be comfortable with that procedure.
I know.
So,
just take care of the anatomical structures, and it's a very easy procedure to do. In fact, even a lay person can do if it is explained to him correctly. That's what I feel.
well, very good, Neha. I thank you very much, and I look forward to the tracheostomy hangout. And that was your first time. Very good.
Thank you so much, John. Thank you so much.
Okay, I'm going to sign off and just hang on. We'll chat. Okay. Thank you very much.
Thank